So without further ado, let me introduce to you our speaker for the day, Geoff Sizer, the CEO of Genesys Electronics Design.
Thanks, Luke, and hello everyone, and thanks for the opportunity to speak to you today. As Luke mentioned, we want to keep this presentation fairly informal, and I'm happy to field questions as we go along. Also, I'll be presenting information that from my perspective is important in relation to the topic at hand, but other members of the audience may actually have areas that they would like to discuss or address. So feel free to use the chat box or raise your hand if there's any topic that I'm not addressing that you think you'd like to cover. I'll probably move through reasonably quickly through most of the topics today, but we can return to any one of them if anyone would like to explore anything in greater depth. So the objective today is to provide a linkage between what's now known as the Internet of Things for connected devices and medical technology. So the medical technology arena is as affected by Internet of Things as much as pretty much any other aspect of technology where we have sensing and communications requirements. For applying Internet of Things concepts to medical devices, there are some particular requirements and constraints and limitations that we need to be aware of, in particular relating to the medical regulatory compliance aspect. So as with just about every other presentation I've given by this community, I will be addressing regulatory aspects, but I won't be labouring the point on them. In terms of the information and clause references and so forth that I'll be providing, this presentation will be available for download, so don't bother about trying to furiously scribble down URLs or clause references to standards. We'll be able to get that from the slide deck. So in terms of the topic, I'll be looking at the items identified in the third paragraph, specifically in relation to Internet of Things and connectivity requirements for medical devices. So just to have a look at a few medical devices that Genesys has been involved or are still involved in developing, all of these devices have connectivity included in them to some degree or other. And that includes local connectivity, typically by Wi-Fi or Bluetooth Low Energy, between sensors and deployed devices and other system elements on site, but also connectivity into medical systems, clinic systems, or hospital systems, and these are all trending to be hosted in the cloud. So we're really talking about end-to-end connectivity right down from sensors that comprise part of medical devices or actuators in medical devices through intermediate systems and edge computing up into the cloud. So just as a quick recap on the Internet of Things and what it actually is, this is a conceptual diagram. It's intended not to be a block diagram per se, but it does actually show the typical elements that you're going to find in an Internet of Things system, with most of the detail presented in the bottom box, which is the, in Internet of Things terminology, the thing, the deployed device that typically would incorporate one or more sensors for sensing parameters, actuators for controlling things, but also typically includes a user interface in some form, display, possibly a touchscreen or keyboard, input-output connectors to sensors that might be deployed, and typically a powering source of some type. So within the context of a medical device, the thing could be a sensing system in a body-worn environment, perhaps for sensing vital signs of the wearer, and that may have sensors distributed around their body for parameters like temperature and perhaps blood oxygen perfusion or blood pressure or blood flow or other parameters relating to the patient, and there are certainly sensors coming online looking at biological markers, for example. So these sensors would then be communicating typically with a body-worn device that would then gather that data and then transfer that data to another device. This is a generic diagram, so it shows wide area network and low power wide area network connectivity. That's probably less applicable to medical devices that are evolving at the moment than local connectivity by Bluetooth Low Energy and Wi-Fi. That's what I'll be focusing on today. But any of the concepts I'm talking about could be extended to wide area network connectivity, such as 3G, 4G, 5G, or Internet of Things type connectivity, low power wide area networks, for example. But the focus, I think, is for medical devices is more on local connectivity to a gateway edge computing device or to a mobile device or to a PC, and then using that device as a gateway to communicate information up into the cloud. So the box at the top of the center is the cloud-based domain. I won't be talking about that in any great detail today. I'll be focusing on the actual device and how it can gather and communicate data. So Luke and Tim, if I start raving on too much, be sure to jump in and move me on.
Will do.
So in terms of the regulatory environment that medical devices operate under, there are two facets to this. One is certification, which is what one needs to do to allow the regulators to permit you to put the device legally on the market in the various jurisdictions. I've just identified a few of the key markets that Australian developers would typically be targeting, and the regulators in that situation. In fact, I've got an error on the slide. The US should be FDA, not TGA. In terms of technical standards, there's a fairly harmonized set of standards that apply across all of these domains. So although the certification requirements differ from country to country, the technical standards that medical devices need to comply with are generally pretty harmonized, which means they align quite well with each other, though there will be some regional differences, and these typically would relate, for example, to mains voltage supply differences and frequencies in different domains, and things such as language. For example, Canada requires things to be bilingual. So there are some regional extensions to these standards, but generally speaking, the core is pretty much recognized across all of the jurisdictions. So that's good news for a developer. You're not facing a whole heap of diverse and non-compatible technical standards. So I'll be touching on specific standards as we go through, mainly focusing on IEC 60601-1. So getting down to communications methods, the primary methods that you're likely to encounter for active medical devices in a typical setting, and that might be a doctor's surgery or a clinic, or it may be a treatment centre of another form, may include operating theatres for in hospitals, and also potentially to equipment that's worn by people in their own home. So there's a wide range of application domains, but the generic requirement is typically to take data from some form of body-worn device or devices associated with the patient, communicate that to perhaps a edge computer or communications gateway, and ultimately communicate data via the internet or to the cloud or to some other location where that information is used, perhaps for a monitoring or a diagnostic purpose. So the technologies that are really most appropriate for this, for short range, low data rate applications, particularly where the device is constrained for energy consumption, Bluetooth Low Energy is probably the technology of choice. If you have a requirement for higher data rates, perhaps slightly longer range, and can tolerate the cost and power consumption, then Wi-Fi becomes the preferred option. And certainly Wi-Fi module and chipset costs are trending down, and energy consumption is trending down with low power mode. So there is actually a convergence of the two. But generally speaking, I'd choose Bluetooth Low Energy for body-worn devices, and the little green devices you see incorporate a Bluetooth transceiver and sensing, and also a little battery, a button cell battery, through to Bluetooth Low Energy modules, and you can also use bare chipsets, and the little dongle plugs into the side of a computer to allow you to communicate the data. In the case of Wi-Fi, the situation is fairly similar. You typically find that the Wi-Fi device will communicate with some form of routing device, typical edge router, or it may communicate directly to a hotspot served by a data gathering device or a PC.
Sorry, Geoff, a quick question because you had the custom RF in the last slide.
Yeah.
Any comments about that on whether to use it or not, or when's a good time to actually use those custom RF?
It certainly has some advantages in particular situations. And I mentioned a 900 megahertz ISM band where it's class license operation, and there are other frequency bands that tend to differ around the world. And 900 megahertz is not universal, it's not available in Europe and UK. So it really, I would only go down the path of a custom RF solution if there is a strong driver away from being able to use Bluetooth or Wi-Fi. And that may be that you have a absolutely ultra low energy consumption requirement. Say for example, you would have an embedded sensor body embedded in the body somewhere. You might want to go to a custom RF solution, and that also of course includes RFID type technology. But that generally the indicators for that is when you have a very specialized need that can't be satisfied by one of the other methods, which just tend to be easier to implement, and the engineering overhead is less if you take a module approach, whereas custom RF, you really do need to have RF engineering expertise. So in terms of the regulatory standards, they're really in two categories, and these go beyond the straight electromagnetic compatibility standards, which still apply. So we have electromagnetic radiation standards, which are to ensure that radiation emitted by a device is not harmful to a human being. Typically certainly for Bluetooth low energy, and certainly to a fair degree for Wi-Fi, there's not a major concern with radiation exposure levels, as evidenced by the fact that people are happy to have Bluetooth devices stuck in their ear, and they're happy to hold a cell phone with Wi-Fi capability up against their head, and that's also transmitting 4G signals, which are an order of magnitude higher power levels than Wi-Fi. So generally speaking, the electromagnetic radiation standards are not a problem to satisfy. You do need to be aware though that there might be contra-use indicators, for example, if someone's got a pacemaker or other embedded electronic device, or for use in operating theatres, for example. But generally speaking, it's not a major concern, but you do need to have devices tested and certified that they do comply with the required limits. The other aspect is radio communications, and this is generally related to making sure the emissions from the device don't cause radio interference to other devices, but it does also address the reception aspect and sensitivity levels and so forth. So you need to be aware of these radio communication standards. It might look daunting if you don't have any knowledge in this space. You might be going, what the solution to that is to engage with an accredited test lab and rely on them to deal with the details of the compliance testing. But nevertheless, your engineering team does need to be aware of the need to comply. And I can tell you some horror stories about people happily importing Internet of Things radio modules from overseas that do not comply with Australian standards. And there have been cases of prosecution for people who've willfully done that. So care is required. So in terms of if you're going to implement Wi-Fi or Bluetooth, you've got a choice to use a third-party module that usually has the chip and the antenna and so forth on it. You can see the little modules there that have got the system-on-chip transceiver, which would typically incorporate a microcontroller. There's a little printed circuit board antenna and crystals and other passive components. These are good solutions for particularly non-experienced developers, because you can get pre-compliant certified modules, and that makes your compliance pathway easier. But if you want to minimize costs and size and really optimize the design, you do have recourse to chipsets. We tend to use the Nordic range of chipsets, but there are others available. And these are supplied by the vendor with the communication software stacks that you can embed on the chipset. So it just gives the experienced designer more flexibility. I wouldn't delve into the area of Wi-Fi chipsets. It's just too hard, and it's much more cost effective to go for a Wi-Fi compliant module than it is to try and use the chipset. And the chipsets are tightly controlled by the vendors. So Bluetooth Low Energy, the chip solution is definitely worth considering, but for Wi-Fi, I'd stick with modules. In terms of antennas, once again, there's choices and trade-off of cost versus size versus complexity versus engineering difficulty. So typically, printed circuit board trace antenna will be lowest cost, but does occupy circuit board space. Chip antennas are a low, relatively low cost-effective solution, but they do need care with circuit board layout because you can't actually just plonk them down anywhere on top of other copper, or they won't work very well. If you need better performance, you can go to patch type antennas connected by connectors, and that may be indicated for particular cases where the circuit board can't egress the radio signals appropriately. And for best performance, you can't go past a whip antenna or a monopole antenna, but that usually is only in devices such as edge computers. You wouldn't contemplate that approach typically for body-worn device. So in terms of designs we would normally go for a combination of onboard patch antennas, chip antennas, or plug-in type patch antennas where we want to optimize the performance or we have other constraints. The next major challenge you face in any medical device design is that of powering, and the decision pathway is by no means clear. It might be, you might think, oh, well, we've got mains power available, let's plug into the mains. But that decision has to be made carefully because you open up vast tracts of IEC 60601-1 relating to mains safety that are not applicable to a battery powered device. So there is a strong indicator for battery powering, particular for body worn systems, not only for user convenience point of view, but also for the regulatory compliance perspective. And of course, we'll talk about batteries in a little bit more detail, but you have a choice of primary cells which are not rechargeable, so single use, versus rechargeable. And in the case of rechargeable, you can have the best of both worlds by limiting the charging to when the device is not in use. So you have it on a mains source battery charger, but not when it's actually in contact with the patient. Probably the nirvana in terms of safety for rechargeable solution is contactless charging, such as Qi charging, which means you can fully seal the device that's in contact with the patient. So you have no external electrical contacts, and that dramatically eases aspects of the regulatory burden in relation to electrical safety. Beware though, you can have issues with the temperature rise caused by the Qi charging. And of course, you need to be able to have a device that you don't need to use 24/7 so that it can be recharged between uses. I've shown a link there of a document I came across. I can't vouch for its veracity, but it looks to be a very useful document in giving overview of battery technologies and their use in battery-powered medical devices. So it's just a handy reference to have. And I've shown there just a few pictures of some typical mains powering devices, and I tend to prefer the external fully compliant device, which is available very cost effectively, and the connection to your device is DC, so all of the mains isolation is incorporated for the AC aspect of that is incorporated into the AC/DC adapter and certified by a third party. So it's a very viable solution. But you can embed compliant certified frame type or frameless converters into your product, but then you have to worry about the mains reticulation in the device. So that opens up big aspects of 60601-1 to worry about. Going down the battery path, you're not totally out of the woods in 60601-1 because there are specific requirements that do apply to battery powered devices, which I'll talk about shortly. Now, you might think, if I've got a 3-volt battery in a device, why do I need to worry about electrical safety? It's not going to electrocute anybody. Well, unfortunately, 60601-1 disagrees, and I've got a couple of references and some highlighted screen caps there that the requirements for insulation voltage resistance and for creepage and clearance distances for circuit boards and wiring and so forth extend down to 0 volts. They don't cut out at any arbitrary voltage below which you don't need to worry. But you will see, talking about operator protection, you don't need to generally worry below 60 volts DC. This is in the so-called safe extra low voltage domain, but there's no such equivalent for patient safety. And this stems mainly from the fact that patients can be in ill health and quite vulnerable, and they can also be in situations where there are conductive paths to their body, at the extreme, conductive catheters into the heart. So you can apply current flow from an inadvertent current flow path directly into someone's heart. Only requires very low currents to cause major issues. So this is why these standards apply right down to 0 volts. It doesn't make sense in some situations if you're dealing with a diagnostic equipment in a generally healthy patient that's not catheterized and not in an operating theatre. You might think some of these things don't make sense, but unfortunately 60601 doesn't give you relief in that regard. So the path of least resistance, excluding the pun, is to just do a design that's fully compliant with 60601-1, not leave yourselves in doubt and relying on risk assessment and so forth. That does impose some obligations on the design, however. So I really just show these references just to highlight the fact that we're talking about electrical safety aspects for battery pad devices. So looking at options and choosing between primary cells and secondary cells, generally primary cells are a good choice wherever you have an energy requirement that allows you to use a primary cell. So they're a low-cost option and they're a safe option. Typically for short-term or single-use sensors that are only used for a short period of time, you can choose alkaline cells, and there is a very good alternative in terms of lithium cells. So the consumer type lithium primary cells, you can get them from Everready, are a very good choice for a non-rechargeable battery solution. You can consider button cells. You consider the cylindrical, from quad A down to double A, that type of cell, or even larger if you need it. There are specialized lithium cylindrical cells in all sorts of form factors, which offer best performance for energy density and shelf life and temperature range, etc., but can be quite expensive. In terms of standards reference, 60601-1 does have a requirement for primary lithium cells to comply with an IEC standard, and there are a whole heap of other standards applicable to consumer batteries. You'll typically find that primary cells from reputable manufacturers will claim compliance with all of the various commercial standards or commercial and consumer standards. If we move into secondary cells, rechargeable lithiums, there is a more rigorous set of standards which apply, 60601-1, 15434, but also this IC 62133, which calls up specific standards, and there are other standards relating to lithium battery transportation, and these will apply to air carriers. So if you're going to lithium primary cells, and in particular secondary cells, be aware that you do have these standards and constraints that apply not only from a medical perspective, but also in relation to transportation. So as is what's the best solution, really it's a combination of use case, energy requirements, cost, convenience, and regulatory compliance. You have to trade all those off before making a choice. Of course, you can go, if you go down a button cell path, then you can have an option of having a primary cell or a secondary cell. So you can actually give yourself a bit of wriggle room. So I'll just maybe pause there a sec. So Luke, are there any other questions that you think might be useful, or has any audience questions come up in relation to powering?
There seems to be two. Well, not really sure what this is. So from Matt Shady, what makes the determining decision to comply between one MOPP and two MOOP?
Yeah, that's quite well defined in the 60601-1. There's a whole heap of diagrams which give you information, but generally 2 MOPP is required to ensure safety of the patient. Can you
remind me what's the MOPP?
Means of patient protection. And you'll say MOOP, which is means of operator protection. So a means of patient protection is effectively a level of insulation or isolation that's required to keep the patient safe. And to keep the patient safe, you need one means of protection. So one 1,000-volt isolation barrier or a 3,700-volt isolation barrier. Where the 2 MOPP comes into play is in relation to single point of failure analysis. So if you've got 2 means of patient protection, either one of them will keep the patient safe, but you have to assume that one of them fails. So therefore, you're reliant on the second one. Also, you can, in terms of where these levels of or means of patient protection are implemented, they don't have to be at the same spot. You could have one means of patient protection in an AC-DC adapter and a second means of patient protection in an isolation barrier in your equipment, for example. But in terms of design, you'll find that the devices that provide one means of patient protection, you can get equivalent devices that are no more difficult to use or costly that provide 2 means of patient protection. So as long as you're careful with your printed circuit board creepage and clearance, you can have isolators which meet 2 means of patient protection, even if you only, strictly speaking, need one. And I tend to follow that pathway because then you're not going to get into an argument with a regulator about where the patient region is and who's touching what when, for example. So it's often best to put in, conservative approach, put in 2 means of patient protection wherever you're not penalising your design by doing so. Then you're not going to have any argument with the regulator. And regulators don't tend to penalise you for over-compliance. Strong indicator, if you can incorporate 2 means of protection in any isolation barrier, it's best to do so.
Just to clarify, so this means of patient protection, is this needed for both batteries and mains powering, or is it only applicable to one of them?
It's applicable to both, and this gets down to this other table. I'll go back up to that previous slide, where you have this means of patient protection, and you can see it's related to voltage, so peak working voltage. And it taught you also have the considerations of protection from mains parts and protection from secondary circuits. So a secondary circuit is something that's not a main circuit, so it can be a circuit that's derived from mains, or it can be a mains independent circuit derived from batteries. So it's all linked to the working voltage that you're dealing with. And the driver for this is you can establish current paths through the patient from any device that's deliberately or in, there are many devices deliberately electrically contact the patient. Others can inadvertently electrically contact the patient. And you can set up current paths through pathways such as a physician or operator touching the patient, or the patient touching other things, or lying on a conductive surface and touching something else. You can have current paths set up that allow currents derived from a battery to have a pathway through the patient. I mean, to give an extreme example, a battery pad defibrillator generates very high and potentially dangerous voltages, but those are derived from a battery pad source. So the fact that the energy source is a battery is kind of irrelevant in terms of whether there are potentially dangerous voltages present. And as I mentioned before, it's difficult to electrocute someone with a 3-volt battery, but nevertheless, 60601-1 is fully focused on current flow of the various types of current, leakage currents and patient auxiliary currents and touch currents. And it's beyond the scope of today to go into the detail, but all of those currents can flow in various places through the human body through inadvertent conductive circuits. And that's the whole basis. There's a long-winded answer to say that 60601-1 applies to either mains powered or battery powered.
Right, there's 2 more questions. Well, we do have time, right? So.
Yeah, I mean, I'm happy to continue on until 1 o'clock.
Yeah. So yeah, maybe we can try this one. So, well, question from Genesys: do we have to worry about safety when the battery is easily removable? For example, when a child may swallow the battery.
Yeah, that's not the removal of the battery and inadvertent harm. That's not specifically addressed by the medical regulatory standards. But it's a more generic safety requirement, and so it gets more into the consumer side domain, rippling across into the medical domain. There are specific requirements for medical relating to replaceable batteries in terms of, firstly, replacement by the wrong type of battery cell, and secondly, inadvertent incorrect installation, in particular putting the batteries in back to front and protection for those sorts of things. So a strong indicator, any design we do will have a battery protection fuse to protect against battery overcurrent, and have a protection device after the fuse to act as crowbar protection. So if the battery is put in back to front, it will open the fuse. If the wrong sort of battery is put in, it will open the fuse. Or if there's a catastrophic downstream failure, the fuse will open to prevent potential temperature rise or even fire risk due to the battery. So there are protection measures, and in the case of replaceable batteries, that goes beyond just the fusing type thing. So it is using the wrong type of battery, and it all comes down to risk analysis. So for example, if you have a critical application where the battery is really critical to the use case, you might want to have a non-user replaceable battery. The battery can only be replaced in a service center, and that then indicator is to use a special tool to access the battery so that the Joe Bloggs out in the field just can't pop the compartment open and put in the wrong sort of battery. And the same thing applies to use of AC-DC adapters. Risk management tells you that you should have means to prevent an unauthorized AC-DC adapter type being used. So you might specify medical safety isolation in the adapter, and someone comes across with an ill cheaper one from China that's got no safety isolation and plugs in. So you really need to avoid that by means such as using unique connector types and so forth and so forth. But let your hazards analysis as part of your risk management be your guide as to what to do.
Cool. We have questions in the Bluetooth Wi-Fi area, but I think we should just move on, and then we'll just go back to that later on.
Okay then. So there's a couple more different classes of topics to address. I'm going to talk about displays and user interfaces, and the regulatory standards that are the core ones applying to this. 60601-1 is quite extensive on user interface aspects as they affect safety and essential performance, and calls up a standard 62366, which is usability engineering, and that is very heavily focused on the usability aspect of devices, and that includes the user interface. And the core thrust of that standard is to make sure that a device is engineered to minimize risk to the patient or the operator arising from misuse, and it requires extensive testing and trialing and investigation to demonstrate usability, and usability is of course very strongly linked to user interfaces. So in terms of user interface, in a sense of maybe a body-worn device that has a display in it, or a need to send data to maybe a mobile device app that's displaying data, or you have a data collection device that's got a display in it for displaying data, right through to quite sophisticated devices with complicated user interfaces. So there's a broad range of requirements that you need to consider. So back to the old school knobs, switches, LEDs and buzzers. They have their place. I've shown there a screen cap of a ventilator, and in this COVID situation, there have been a number of emergency respiratory ventilators developed that use very basic user interfaces with dials and knobs and LEDs and buttons. The primary driver to that is simplicity of implementation, simplicity of guaranteeing function, and also simplicity of use. So if you are considering a ventilator for use in third world countries by relatively inexperienced operators, in my view, you can't go past very simple user interfaces that are pretty foolproof. One thing to be aware of, a trap for the unwary, is the use of indicator colors, and the new version of 60601-1, or the new amendment, Amendment 2, has got much more specific in terms of what you can and can't use an indicator for. To my mind, it's actually a little bit flawed because it doesn't actually mention orange, and I've seen people happily put orange indicators on medical devices. So what's the difference between red, yellow and orange? Sort of beauty is in the eye of the beholder, and to me orange is a form of severity of indication in between red and yellow, so shouldn't really use orange just for general functions. So that really leaves us pretty limited in what we use indicators for. Basically red or yellow in various manifestations for warnings of various severity, green for all is okay, and you're pretty much left with the only other option being blue for indicating other stuff, such as typically blue is used for Bluetooth link connectivity or Wi-Fi link connectivity. But beware if you're looking at using coloured indicators for functions to not run foul of that particular requirement, and that is fairly hot off the presses. The old 60601-1 was vaguer, was similar in some respects, but was vaguer and more open to interpretation. But this current version is pretty restrictive in what you use indicators for.
So Geoff, out of curiosity, has there been medical devices where they just forego of all the knobs and switches and won't make it easier for compliance purposes or whatnot?
Well, if you have no user indication requirement, that's the case. So, for example, if you've got a body-worn sensing system, what's on the user's body might have no indicators on it whatsoever. Though typically you would find some form of power or ready indicator, but certainly could be very minimal. However, any device to be useful needs to do something. So you need to control it, or you need to gather data from it and display it. So at some point in the system, you inevitably will have some form of user interface, even if that is on the far end of a cloud-based database for displaying sensor information that's been consolidated and processed. So you will have in your medical device system some form of user interface somewhere in the system, which is a good segue into the next slide. So being ourselves kicking and screaming into the 21st century, modern user interfaces these days are very centric on sophisticated and highly capable displays, typically LCDs or OLED, with touchscreen interfaces, the sort of thing we're all familiar with every day from using mobile phones and mobile devices. So there's a very strong driver for a similar approach to be used for user interfaces for medical devices. And this, of course, brings us into the domain of using a mobile device as the user interface for your medical device. And there's a very strong trending in this direction. But a couple of points to ponder. Firstly, moving into the use of a mobile device, you have IEC 60304 compliance issues caused by what is called SOUP, software of unknown provenance. I'll talk about that a little bit later on. But it means software that's not been developed under 60304 that you are reliant upon. And so this is a particular concern if you're using a mobile device as your primary user interface. I've chickened out on a couple of occasions, and the TrueScreen device shown as a good example, where we have a built-in simple LCD, which is the primary user interface for the medical device function, and anything that appears on a mobile device or a PC screen is secondary information. So this at least brings that software down into the 60304 Class A category, where SOUP is much less of a concern. But if you've got SOUP in your Class B device, you have a big burden for verification. Of course, we can't get away from that if we're using, for example, Bluetooth devices with built-in protocol stacks. You still have SOUP in your system that you need to deal with. But it's just something to contemplate. Don't immediately think I'm going to use a fancy PC screen or a touch screen or a tablet or mobile device as my primary user interface, because it does bring a regulatory burden in spite of all the benefits it brings. And of course, in this day and age, everyone likes a machine that goes ping. So there's a strong driver. You can see the couple of screen caps there from an operating theatre and an intensive care domain, where you can see very extensive use of touchscreen type user interfaces. And anyone who's been following anything about COVID will see this pop up over and over again in the intensive care domain. So it's definitely the way of the present and the future. So bringing us to mobile device apps, might say, well, is the mobile device app a medical device? All depends on how you're using it. If it is an integral part of the application of the medical device, then it's part of the medical device. You can't say, oh, it's just the user interface, it's not part of the medical device. And this brings us into this software of unknown provenance compliance issue. I'm not going to go into detail of that today, but it does mean any software that's not under 60304 that you don't have control over, you really have issues in terms of how you go about validating its function. Of course, there's a temptation with user interfaces to overcomplicate them. If you do that, you're going to run foul of the usability requirements because if you're introducing scope for misuse. So you really need to keep the user-facing part of this very simple, particularly if it's in a high-intensity environment such as intensive care and operating theatre. You don't want to have multiple layers deep of menus to find out what the flashing red light means, or the user's just going to simply get overwhelmed with information. Many of us may have actually watched things about information overload in aircraft cockpits that nearly brought down a Qantas A380 because of huge numbers of cascading alarms that were never anticipated by the designers, which simply overwhelm the people receiving those alarms with useless information. Doesn't help them. The same can apply in an application. So it's really a case of KISS principle. Keep it simple, keep it clear cut, and don't overcomplicate just because you can. So I'm going to move on to another topic. So any queries or questions on user interfaces and mobile apps?
So far, none.
Okay, we can return to that at the end. So I've got a bit of a scattergun of topics here, but just things that important to consider. So move on to storage, and this goes from anything from local storage on a device right up to cloud storage. And down at the device level, even the simplest of low-cost, low-power device can have local storage included on it cost-effectively. So generally, the bare minimum we'd expect to see in any design we do would be a small double EEPROM with maybe a few tens or a few hundreds of bytes of storage capacity used for local parameter storage for configuration, calibration parameters, for example. Also, perhaps for signatures that indicate that a device has been through its final unit production test, and a serial number. And the microchip device there, less than 50 cents, small device, very handy because it's got a unique EUI64 identification code in it. So you can use that as an electronic serial number. So in terms of additional sensors, it's perfectly reasonable to consider putting a SPI flash chip of maybe a few megabytes capacity right down on a sensor, so you can store and log data and for preservation and recording right down on the actual sensor itself. When we move into perhaps more complicated devices, edge computers, a really cost-effective solution is to embed an SD card on the device. For under $10, you can get 100 gigabytes of storage, which for many devices will store all the data it's ever going to gather for its entire lifetime. That's important if you're considering redundancy in terms of the location of that data. And that can ease your regulatory compliance burden for the communications link getting that data up into the cloud, because you can say, well, we can always get the device, retrieve it, pop the SD card and get access to all the data. So if the data is not required in a timely manner, you have an escape hatch that can allow you to have redundancy in terms of your data storage. So moving up the food chain, we're typically then looking at getting data off your device through an edge computing device or perhaps directly into a mobile device. Then that data can be egressed from that device into cloud storage. So you can have a cloud-based server system, and that typically comes into play where you have a large deployed base of multiple sensing devices and you want to store and consolidate that data in the cloud. But of course, at any point in the communications link and storage link, you need to be aware of what the generic term for it is trustworthiness, and this encompasses all of the principles of validity and security, privacy, reliability, redundancy, etc., etc. There are specific requirements called up by 60601-1 and 62304 that relate to the integrity of data when you're communicating it. And this relates to making sure that communications protocol packets have robust CRC protection, for example, making sure that you have guaranteed data delivery by the various protocols you're using. When you get into an environment where data could be intercepted or perhaps even manipulated or falsified, you then need to have integrity measures, and encryption, and the security measures around that are effective means of providing that level of protection. There are a range of emerging government regulations, and they will ultimately be backed up by standards for patient privacy, cybersecurity, etc., etc. So watch this space. Anyone involved in any system that requires data to be conveyed at any point from a device through to a mobile device, through to perhaps a hospital or clinic data system, and ultimately up into the cloud, really needs to be aware of these regulations and standards that are emerging in the privacy and cybersecurity domains. So no questions in that space?
So I have a quick question about, so if you have, let's say, an SD card with your device, does that SD card need to be somehow encrypted for in line to the privacy that you just mentioned?
I guess it depends on the threat. I mean, if that device is totally in the custody of the user, typically in a hospital clinic where there's physical security, you could argue the data doesn't need to be protected. But if that was, for example, in a home monitoring environment where you have an SD card that potentially can be stolen or misused or accessed, then there is an argument that you might want to encrypt the data. But typically speaking, we tend on devices where there's physical security and custody not to encrypt the data. Of course, as soon as you encrypt the data, then you bring a vulnerability. What if something goes horribly wrong and that encrypted data gets corrupted, or you lose your decryption key or so forth, you might lose data. So there's always a trade-off. So I tend to err to not encrypting or not even compressing data, just having raw CSV files of data stored in dual redundant form, of course, on 2 partitions on an SD card with dual redundant storage, with CRC protection of files, but just in raw form so that there's a minimum risk that that data can get lost. But as soon as you have any form of physical or electronic security threat, it might be an indicator that you want to encrypt that data, but then you have the issues of key management. And there are other devices that you can install that are equivalent to that microchip device, but actually for use for encryption keys. So there are systems and methods to do this. So once again, let risk management be your guide and do a trade-off between the security and privacy threats vis-a-vis the ramifications and threats of loss of data. So next topic, let's have a quick look at...
There's two more questions on the topic.
Oh, sorry.
Yeah.
Right.
I was muted.
Let you tell me when to move on.
So if a medical this is slightly related. I think if a medical device has already gone through medical compliance, so that's before, let's say it's an old version without a communication module. So in general, what needs to happen if you want to add a communication module to the product?
I mean, that can get tricky if the device itself can't be changed. In other words, you can't do anything to the software or its component parts. You might be very limited, and in the worst case, have to embed that in some sort of applique that provides security to the communications. But if, for example, the device, you can do a software update on it, then it's quite feasible to incorporate data trustworthiness measures, in particular redundancy, checksum protection, and encryption measures can be incorporated by a software update to the device. You may, in a situation where you have a sensor that's egressing data to a gateway device, or maybe you leave that link as is, but then do the updates to the gateway device. And of course, the regulations they tend to have grandfathering clauses, so you can continue to use previously compliant devices that don't meet the new regulations up to a certain date, and then you have to move over. But this has got particularly tough in Europe, where they're saying there are drop dead dates where everything needs to get put through compliance to the updated standard. So that means a lot of old devices will simply just come to end of life because it's too expensive or difficult to do that updating. But I would imagine most devices that are embedded software microcontroller based, you probably would have a means of a way forward by doing a software update.
Okay, and then the next question is, in a medical device, what are the redundancy requirements for data storage, if any?
Once again, fall back to the hazard analysis and the risk management. It depends what is the criticality of that data. So if it's highly critical data, then you can have a paradigm where as soon as that data has been egressed securely to another platform, and you've got acknowledgement that that data has in fact been received and stored by that platform, the device itself may no longer have any need to secure that data and can simply delete it. If data is transmitted immediately when it's gathered, then you don't necessarily need to store it locally. but devices that I'm involved with, we generally store it locally as a redundancy measure. So part of a hazards analysis is to use redundancy. So we store it locally, we egress it, we keep it for a certain period of time. And then this also lets you say, well, the egress method might be a Class A software rather than Class B. So if that data is not needed immediately at the other end, it's just something you're storing and sending forward and processing later, you can then argue that if the communications link fails, you can always retry, or you, at the extreme, can go down to the device and retrieve the data directly from it by some other means. So you can use it as a risk management tool, and that then indicates that the data needs to be stored robustly and typically redundantly. But if the data has no meaning after you've transmitted it, then any storage locally would be much less stringent requirement. I think the approach is to say, well, if we want to store data locally for any reason, we can do that cost effectively, either with a flash memory chip or an SD card. Then on those chips, have enough capacity to store it redundantly with checks on protection. So you've got 2 copies of it in the event of software bug. Of course, if the physical device fails, it doesn't work, but then you can maybe have critical data on the flash chip and backed up on the SD card, so you can have dual redundant storage on the device. And all comes down to a case of cost versus capability versus power consumption versus risk. But to give you an idea, if we're currently involved in a body-worn device, and it's incorporating microcontroller with serial flash chip for critical short-term data storage and an SD card for longer-term data backup. And the incremental cost to the system of putting those on is about $10 on a device that's going to cost thousands of bucks. So it's really an easy decision to make in that case.
Cool. Yep. We're getting to the end of the time, so please proceed.
Yeah, I've got only a little bit more to talk about. So in terms of our embedded devices, I've got here a few examples of typical devices that one might use. So system on chip devices or purpose-built embedded microcontrollers. This day and age, you'll almost certainly be using something with a 32-bit ARM core, Cortex M0, M4, or further up that food chain if appropriate, but those cores are more than capable for body-worn or embedded or implanted or not implanted so much, but devices that are induced into body cavities, etc., associated with therapeutic and diagnostic functions. Those classes of microcontroller are more than capable of serving the need cost effectively. And if you've got a Bluetooth transceiver, it's got the microcontroller core built in, so you often don't even need another processor there. Though you do need to consider aspects such as over-the-air software updates, which might indicate having a second processor core has its benefits for anti-bricking. So in terms of operating system, at Genesys we would use anything from bare metal, which is operating system free, but we actually have our own proprietary operating system, not cooperative multitasking, but using interrupt domain type multifunction processing capability. And that's for simple devices or where you want the absolute maximum robustness. For medium complexity applications, we would tend to use RTOS, real-time operating system, and the inexpensive, in fact, free choice, free in terms of no third-party licensing, real-time operating system is available from a number of vendors for various platforms, and you typically find ST have a release of that for their processors, as do the other microcontroller vendors. And it's typically our primary go-to choice for anything other than really simple type devices. You can, of course, if you have deep pockets, go for safe RTOS, which is the equivalent of free RTOS, but comes pre-certified for 6304 compliance. I've had quotes for that recently. You're talking about minimum entry costs of about $20,000 for a single product. So it's not a cheap solution, but in terms of procurement costs, but your compliance cost could of achieving compliance based on free RTOS could easily eclipse that for a relatively complex device. So it's well worth considering the cost of going to safe RTOS. You can develop under free RTOS and move across to safe RTOS partway down the pathway if you want to defer that expenditure. Embedded Linux, I'm on the record of saying I'm not a great fan of using Linux for anything, but for a medical device, for anything other than Class A, I would absolutely shy away from it, simply because it's just tends to be such a pig in a poke in terms of the Linux release and how it's controlled. And certainly any of the open source Linux releases are not 6304 compliant. So it's a big question mark about whether you should contemplate going to Linux. Others may have different view. My personal view is try and avoid it at all costs for the critical medical device function. If I have a design that needs to have web access, for example, I would perhaps use a Linux platform for the web interface part, but would manage that as a Class A device and make sure that the device critical functions and data regress and anything that really needs to be 6304 compliant is done by a companion processor, typically running RTOS, FreeRTOS or SafeRTOS. So I split up the functionality so I get the best bang from a buck out of the Linux for the stuff it makes sense for, but don't burden my whole product with a regulatory compliance constraint of having Linux as a big chunk of soup. Don't underestimate the 6304 compliance burden. To do it properly, it is quite onerous. Having said that, it does align with software engineering best practice, but either way you look at it, it is a big burden on a project which developers who've never come across it before think, oh, I won't worry about that, or I'll get someone else to do that later. It simply doesn't work. And just a final point, whatever you do, if you're agile, don't be fragile.
Sorry, quick question about embedded Linux. So sorry,
yeah.
I'm a Linux fan, but is the comments that you gave pretty much for embedded operating systems such as embedded Linux and let's say Windows IoT?
Yeah, though it applies to any of those embedded operating systems. Good luck finding a medically compliant 6304 certified variant of it, and if you can find one, good luck affording it. You can get certainly get embedded Windows variants from vendors. Wind River, I think, is another one. There's a couple of them. Wittenstein, they do have them, but they're incredibly expensive, so they'd probably be on the reach of certainly the sort of customers we'd be servicing. They'd really be at the very highest end. So my temptation is to chicken out wherever possible and avoid it. You're inevitably going to be using those operating systems, but try and limit the aspects that those parts of the system are dealing with to Class A if you can, and if they're Class B or higher, be aware for a major compliance initiative to get sufficient evidence that your device does comply with the requirements.
Right, we're a little bit over time, so please move on. I think we're pretty much done.
I've just got one very last quick topic in relation to connectors and cabling. You're inevitably going to come across this with many applications where you're not going to have a fully wireless system. You'll have wires maybe running for a body-worn application through clothing to sensors around the body. Be aware that you do need to meet the electrical isolation requirements for that wiring and the sensors, even for a battery-powered device. Particularly if you've got sensors all over the body, you could set up inadvertent current paths that could actually flow through the heart, so they could become a real potential risk, not just a notional risk within the standards. So be careful about your cable and wire ratings or the insulation where sensors contact the body, particularly if they're sensors not intended to have electrical contact. You need to make sure they're insulated. If they are intended to have electrical contact and pass current through the body, there are requirements for 60601 calls it auxiliary current that you need to be aware of. So just take care in that aspect of the design. And for your connectors, make sure that where connectors go into devices, you have adequate creepage and clearance at that connector interface point. I've just shown a couple of sketches there of a standard finger probe. It emulates finger and a standard probe. There's a hook that you have to be able to poke into any openings in your device and make sure that you maintain adequate creepage and clearance from conductive elements in your device that could set up to inadvertent current paths. Also beware of fluids. So for example, if you've got a device that's body worn and it's used in a situation where, say, in a doctor's surgery where the doctor could in fact have body fluid on their gloves, or even on their bare hands, so you don't have a inadvertent conductive path through fluid leaking into your device, conducting by the surgeon or the physician through their body to maybe touching a metal surface that the patient's in contact with. So you can have these circuitous current paths that are set up that you might not have thought about, that you really do need to be careful about. That brings me to the end.